First, we will tackle the question, what is goal attainment scaling? Throughout the course, we will be referring to goal attainment scaling by its acronym GAS. We will interchangeably use GAS and goal attainment scaling. So, what is goal attainment scaling? It's a technique used to evaluate functional goal attainment. It can help document how a client progresses over time. A goal is made for a client, then the clinician can make 2 objectives that are more than anticipated and 2 that are less than anticipated. The objectives are labeled -2, most unfavorable treatment outcome, -1, less than expected success, 0, expected level of success, which is the actual goal, 1, more than anticipated success, and 2, best anticipated success. The clinician can combine all of the scores from multiple goals to get an overall goal attainment score. This process will be talked about later in the course. GAS was developed by Kirasuk and Sherman in 1968 because they wanted a better way to measure change with their clients. They worked in the mental health population. They found, using GAS, it was a better way to document change and could help them constructing their abstract goals. When this article was published, Kirasuk and Sherman advised that goals be weighted, more important goals with more weight. But later, in 1994, when they published their book, they advised that with new statistical methods, the weighting system was no longer needed. In 1979, Citterbaum and colleagues conducted a literature review in GAS. At this time, GAS was considered the most popular outcome evaluation technique in the human sciences. It wasn't until 1983 when Clark and Caudry introduced GAS to the rehabilitation world. Later, in 1994, the creators of GAS wrote an updated book of the method. This book further illustrated how GAS scaling can be used with a variety of professionals. As you can see, researchers have defined what the -2 to +2 objectives mean. This shows there is not one uniform way to scale goals according to the literature. The column farthest to the right is what the creators of GAS intended each level to be. For purposes of this course, we will use King's scaling method, with baseline equaling -2. This scaling method can be seen in the chart in the second column. Using -2 as the client's baseline will make goal setting more clear and easier to understand. This is an example of scaling goals for a client from Kirasuk and Sherman's book in 1968. Take some extra time if you need and pause the video to take a closer look at this table. In this example, there are 5 different goals that they are using for one client. They have scaled each goal accordingly, -2 to +2. The person selected was in the mental health population. In this example that Kirasuk and Sherman pick, you can see there is a weight placed on the goals. This is no longer advised and will be explained later in the statistical section. Just take a quick look at these goals and the even intervals between the goals. This is a brief introduction to how the creators of GAS intended for goals to be scaled. There have been many populations that goal attainment scaling has been used with to document clinically relevant change. These populations include community-based mental health promotion, cognitive rehabilitation, acquired brain injury, health promotion, early intervention, the geriatric population, physical therapy, occupational therapy, and speech therapy. Later in the course, you will see how different populations can be used with goal attainment scaling by completing a case study assignment. Carol Conway will be providing her feedback throughout the course. She is an OT in the schools who would love to start utilizing GAS in her practice. She taught a guest lecture about GAS in a course at Cleveland State University's Occupational Therapy program. I'll let her introduce herself.
Hi, I'm Carol Conway. I'm a pediatric occupational therapist who works in the school district in Hudson City Schools. I have been an occupational therapist for 33 years. I've been in the schools for the past 24 years, and prior to that, I worked in outpatient rehab in pediatrics, and I have a master's degree in psychology.
We also asked Carol, do you see GAS being useful for all populations you work with? Here is her response.
I think I could really use it with all my clients in school-based practice because it correlates so closely to an IEP objective, and the IEP objective, of course, is legislative, and I need to do it that way, but I need to measure progress in a way that has a numerical value, and so I do feel like I could use this for all my students.